Good afternoon, everyone. This is Carla Thorpe again from the Mental Health Commission of Canada. Thank you very much for joining us today for our webinar on substance use and suicide among youth, prevention and intervention strategies. This webinar is part of the Mental Health Commission of Canada's webinar series on suicide prevention, and we really thank you for joining us for the session today. Just before we get started, I'm going to go through a few housekeeping items. We'd invite you to send any questions or comments to us throughout the course of the webinar using the chat feature. If you don't have the chat feature showing up for you on the right-hand corner of your screen, there's a little icon on the upper right-hand corner that says chat, and there's a little conversation bubble above it. You can click on that, and then the chat window should open up for you. We would encourage you when you're sending your questions or comments in today, if you could select from the drop-down menu, make sure you're sending those to all panelists, and that way our presenter as well as those of us behind the scenes here at the Mental Health Commission will all receive those questions so that we can ask them on your behalf. Our webinar today is also being recorded and will be archived and posted on the Commission's website in the webinar archive section in about 2 weeks' time after the webinar. We'll also be posting a copy of the presentation deck from today in both English and French so that you can access copies of the slides afterwards as well. We do have a large number of participants that are joining us today, so we have muted all of your telephone lines already automatically upon entry into the webinar this afternoon just to eliminate any background noise. So suicide prevention is a high priority for us here at the Mental Health Commission, and certainly is being considered a national health priority across Canada. We do know that currently in Canada about 4,000 Canadians die by suicide every year, and certainly there's a far greater impact than that as well when you consider all of those that are affected by suicide, including family and friends and other loved ones as well. There's a lot of activity going on in Canada right now around suicide prevention. Some of you may have seen in late fall, the federal government released its federal framework for suicide prevention, and there's work that's currently underway to implement some of the activities that are specified in the framework. For us at the Mental Health Commission, we're really guided by the Mental Health Strategy for Canada, which is called Changing Directions, Changing Lives. And there were several important strategic priorities related to increasing awareness and capacity for suicide prevention in Canada that have really been guiding our efforts here at the Mental Health Commission. We certainly know that suicide is preventable, and there are many organizations across the country that are implementing innovative programs and really focused on increasing support for people, increasing awareness, and really in a concerted effort to decrease suicides across the country. So this webinar series is really an opportunity to feature some of those innovative practices that are going on across the country, as well as some of the latest research that's going on in the area of life promotion, suicide prevention, but also postvention and intervention across the country. So we're very delighted today to introduce our speaker for today's webinar, Robin McQuaid. Robin is a research and policy analyst at the Canadian Centre on Substance Abuse. She completed her PhD in neuroscience from Carleton University, which is located here in Ottawa. Her research has taken a biopsychosocial perspective, examining how both biological and psychosocial factors interact to promote or buffer against mental health and substance use disorders. As I mentioned, Robin is with the Canadian Centre on Substance Abuse, which is Canada's only agency that has a legislated national mandate to reduce the harms of alcohol and other drugs by advancing knowledge to inform policy, practice, and programs. So we're very delighted, Robin, to have you here with us this afternoon, and we'll turn things over to you to get us started with the presentation.
Great. Thanks so much, Carla, for that introduction, and thank you everyone who has joined in today to listen. And as discussed, I'm going to be presenting on substance use and suicide among youth with a focus on prevention and intervention strategies. So there really is limited data and activities that focus on substance use and suicide concurrently in Canada. At CCSA, we released a topic summary focused on these co-occurring issues, specifically among youth. So today, a lot of what I'm going to be talking about is drawn from this topic summary that can be found on our website. The focus of today's learning objectives are to learn about the relationship between substance use and suicide, learn about the risk youth at risk for suicide, and to learn about the prevention and intervention approaches that's focused specifically on substance use and suicide. So just a brief outline of what we'll talk about today. I'm just going to give, Carla gave a brief introduction of CCSA. I'll also just give a little bit more information for anyone unfamiliar with who we are. And I'll just provide some context in terms of prevalence statistics around substance use in Canada and suicide. And then we'll focus in on our learning objectives. So for those of you who are unfamiliar with the Canadian Centre on Substance Abuse, or CCSA, we are a not-for-profit organization created by an act of Parliament to provide leadership to address substance use in Canada. And we provide national guidance to decision makers by harnessing the power of research and curating knowledge and bringing together diverse perspectives. So I think we're all aware that substance use disorder is a disease and it creates a significant burden on society. So in terms of the financial burden, problematic substance use costs over $40 billion per year in Canada alone. So we have a number of priority areas at CCSA, and today I'm going to be focusing in on discussions around co-occurring issues, which is one of our priority areas at CCSA. So we'll just start with that by giving some context in terms of the extent of substance use in Canada. So we know for alcohol, about 1 in 10 individuals report exceeding the low-risk drinking guidelines, which is 2 drinks or more a day for women, and for men, 3 or more drinks a day. When examining alcohol in the past 12 months, when we look at gender, 80.6% of males and 71.2% of females report using alcohol, and that's a general population statistic. When we look at cannabis, we can see that about 1 in 10, or 10.6% of the general population reported cannabis use in the past year. And for youth aged 15 to 19, 22.4%, or about 1 in 4, report cannabis use in the past 12 months. And those youth aged 20 to 24 or higher at 26.2% who use cannabis in the past 12 months. When we look at gender, we can see that the prevalence is higher among males, so 13.9% of males and 7.4% of females reported cannabis use in the past 12 months. When examining opioid pain relievers, it's approximately 1 in 10, or 14.9%, who report past year use. And for gender, 14% of males and 15.7% of females report use. When considering opioid abuse, 2.3% report abuse. And when we consider substance use disorders, we know that about 4.4% of Canadians aged 15 and older met the criteria for substance use disorder in the past 12 months. So there are some specific populations at risk when we consider substance use, and I'm going to specifically focus on youth later and throughout this talk. So I just wanted to highlight that Canadian youth had the highest past year use of illicit substances. That's among 15 to 24-year-olds and compared to other Canadians. We know that Canadian youth are 4 times more likely than adults aged 25 or older to report harm because of drug use. And Canadian youth aged 14 to 24 who were being treated for substance use problems, 50% of females and 10% of males reported sexual abuse. So this is just demonstrating the link between abuse and trauma as risk factors for substance use. So we're going to focus, like I mentioned, on youth. It's a particularly important population to consider when we talk about substance use in terms of the ongoing brain development that's happening during this time. But I wanted to also briefly mention that older adults are also being considered at-risk populations when we look at substance use. They're a rapidly growing population, and it was found that 18% of older adults, so 65 and older, are hospitalized because of heavy drinking. And recently there was a report by the Canadian Institute of Health Information and CCSA. So we put out a joint report on opioid poisonings and learned that seniors actually had the highest rate of hospitalizations due to opioid poisonings among all ages. But when we considered intentional poisoning, so this report looks at intentional poisonings as well among all age groups, and they found that intentional poisonings were most prevalent for youth who were 15 to 24, followed by young adults aged 25 to 44. So I wanted to also provide some context in terms of statistics surrounding suicide in Canada. In 2012, 11.4 deaths by suicide occurred per 100,000. Suicide rate is higher for males, so 3 times higher among males and females, and men aged 40 to 59 have the highest rates. The suicide rate in some Indigenous communities in northern Canada are some of the highest in the world. So, for example, Nunavut has one of the highest rates, which is 63.5 deaths by suicide per 100,000. And while men in their 40s to 50s have the highest rate of suicide, suicide is a particularly important issue to examine among youth, as it's the second leading cause of death among youth aged 15 to 24. So we know that completed suicides represent only a portion of the public health issue. As for every completed suicide, there are many attempts and suicide thoughts and ideations. So in 2002, it was found that 7% of youth aged 15 to 19 years reported suicide ideation in the past year, and this compared to less than 4% of all Canadians aged 15 and older. Hospitalizations for intentional self-harm from 2009 to 2014 increased by 102% for girls, and these hospitalizations due to intentional self-harm were 4 times higher on average among girls than compared to boys. In 2005, there were greater than 5,000 hospitalizations of youth and young adults who were aged 15 to 29 years, which was attributed to attempted suicide. And females accounted for 66% of these. So this just provides some context in terms of the issues that we're discussing today. And with that, I'll get to the first learning objective, which was to understand the link between substance use and suicide. So while suicide is often viewed as a mental health issue, particularly resulting from affective disorders such as depression, there is a strong body of evidence that shows that suicide and substance use are consistently linked. And it was found that about 90% of Canadians who died by suicide had a substance use disorder or mental illness at the time of death. It was also found in 2002 that 603 deaths from suicide in Canada were attributed to alcohol use, and an additional 295 were attributed to illegal drug use. The risk of suicide for adults is also elevated 9.8 times among those with an alcohol use disorder, 13.5 times for opioid use disorder, and 16.9 times among those with polysubstance use, so using multiple substances. Due to the strong association between substance use and suicide, there really is a need to identify whether effective prevention and intervention strategies exist for youth who present with these co-occurring issues. So those stats on the last slide were among the general population in adults, but suicidality and problematic substance use often emerge in adolescents, making this developmental period a really important target for efforts in prevention and intervention. And one prominent but ignored risk factor for suicide attempt is a high incidence of alcohol or drug use disorders. So a review paper among adolescents found that 27 to 50% who died by suicide met the criteria for a substance use disorder. It was also found that the rate of problematic substance use was 7.5 times higher, and problematic illicit drug use was 8 times higher among adolescents who died by suicide compared to community controls. Rates of alcohol and other substance use disorders among adolescents are as high as 50% among those who attempted suicide. So these data make it clear that identifying ways to prevent suicide among those with substance use issues is really critical to addressing the overall public health issue of suicide. The disinhibition caused by certain substances, such as alcohol, can facilitate suicide ideation and increase the risk that individuals will act on suicidal thoughts. So in some studies, they found that almost half of adolescents who have attempted suicide reported having consumed alcohol at the time of an attempt. Now, these stats can vary, so 50% would be the highest stat that I've seen, but I've also seen some statistics that are varying between 35 and 50% of those who attempted suicide consumed alcohol. We also know that the link between alcohol and suicide is fairly evident and consistent, but the link between suicide and other more widely used substances such as cannabis is really less established and more research is required. There are a couple longitudinal studies that do speak to regular cannabis use as a risk factor for suicide, but certainly the research is not extensive and further research is needed. We do also need to point out that the directionality and causality between adolescent substance use and suicide behavior is unknown. So there are several theories that have been proposed as to why the relationship between substance use and suicide exists. It could be that the link between substance use and suicide is more of a distal or removed relationship, and there are many pathways through which this could potentially occur. It is possible that individuals who experience depressed mood could be more likely to turn to substances to self-medicate or cope, which can potentially lead to results of breakdown of relationships and connections and in turn suicide risk, but certainly that is just one possible pathway of many. We also know that it's been suggested that substance use could be more directly related to suicide behaviors, as substance use is associated with higher levels of disinhibition and impaired judgment. This could potentially increase the risk for suicide behaviors. So these are really complex relationships, and in most cases there would be an interaction of multiple factors that is responsible for this relationship. Now, there are a number of research gaps regarding suicide and substance use that could help inform prevention efforts. So, for example, there's a lack of data on the influence of acute use of substances on suicide risk and the progression of suicide risk across substance-using events. The implications of substances, like I mentioned, other than alcohol, so such as cannabis, is really poorly understood, and further research is needed in this area. We also need a better understanding of the motivations for substance use prior to suicide. It's particularly important as substances can be used deliberately to reduce psychological barriers such as fear in an effort to engage in suicide behavior. And something that I'm going to talk about a little bit later is the lack of evidence examining the efficacy of suicide prevention programs for individuals with co-occurring substance use and suicide. So now that we've covered the relationship between substance use and suicide, we are going to move on to learning objective number 2, which is really understanding at-risk youth. So we certainly know that not all youth who use substances are at risk, but understanding what some of those contextual or cultural factors are that might put youth at risk could help inform targeted prevention initiatives. There is some emerging evidence that early onset substance use is a possible risk factor for elevated suicide risk. In a sample of almost 14,000 high school students, it was found that early age of onset of alcohol use was associated with greater reports of suicide ideation and suicide attempts. It was also found that youth who began having alcohol use issues during their teens were 4 times more likely to have experienced a suicide attempt than those who began later in life. So there's certainly some evidence suggesting that early onset might be a factor in these relationships. Another risk factor to consider is having comorbid conditions. So comorbid affective disorders and substance use disorders greatly increase the risk of death by suicide among adolescents. It was found that the risk for death by suicide for individuals with both a substance use disorder and affective disorder was 17 times higher than matched controls. So these data might indicate that it would be important for healthcare providers to monitor suicide risk among youth who are presenting with early onset or comorbid conditions. We also know that suicide is a gendered issue. While males outnumber females in completed suicides by 3 to 1, females attempt suicide more often. And when it comes to substance use and suicide, it might be that females are at increased risk. So this increased risk could be due in part to females who use multiple substances, so polydrug use. As females with polydrug use and a history of suicide attempts showed an 87-fold increase in suicide risk compared to the general population. A meta-analysis also showed that females with an alcohol use disorder had a 17-fold mortality rate for suicide, whereas males had a 5-fold mortality rate. And I've mentioned the opioid report by CHI and CCSA earlier, but in this report, again, this trend was consistent that females had the highest rates of intentional opioid poisonings. So those stats are really among general population and adults, but speaking about youth, specifically it was found that deaths by suicide due to alcohol and drug toxicity were significantly higher in Ontario females, and those females were aged 16 to 25 compared to males. It could be because males are more likely to use other means. So for example, in this same study, they found that suicide by shootings were much higher in males. And the increase, so the 102% increase I've discussed in self-injury among girls between the years 2009 and 2014 was largely attributed to intentional poisonings. So 88% of the cases were intentional poisonings with substances such as prescription medications, illicit drugs, and alcohol. So with respect to this last point, this fact kind of raises the area of intervention through the restriction of means to complete suicide. And for example, what I mean would be ensuring safe storage and monitoring of prescription medications and other drugs in the home should be a cautionary approach for parents to adopt. We also know that Indigenous youth have especially high rates of suicide. So death by suicide is 4 to 5 times higher among First Nations peoples and 11 times the national average among Inuit. Inuit youth have suicide rates that are among the highest in the world. There was a study by Kermeyer that looked at Inuit youth suicide attempts and found that for females, they were tied to recent alcohol, cocaine, or crack use, whereas for males, recent life events and solvent use were the strongest correlates of suicide attempts. You know, this is an area that is needing further research. We're really uncertain if or to what extent at all substance use contributes to the amount of deaths by suicide among Indigenous people. It's certainly an area that we are starting to examine, and I've just recently completed some data analysis at the First Nations Information Governance Center examining the relationship between substance use and suicide outcomes. So we'll be working on that report next year. We also wanted to mention other minority groups elevated suicide risk has been consistently reported among LGBT youth populations, and the rates of substance use were 190% higher among the LGB youth than the heterosexual youth, and even higher among certain populations within this group. So among bisexual youth, they have the highest rates of substance use. And it has been suggested that the elevated suicide behaviors among LGBT youth have been associated with substance use disorders. So in spite of some of the growing research indicating that high rates of suicide behaviors do occur in minority groups, there's limited information on effective, culturally sensitive, problematic substance use interventions for minority groups with elevated suicide risk. So this brings us to our third learning objective, which was really to focus on prevention strategies for youth with co-occurring issues. And I just wanted to mention, and Carla certainly mentioned this at the beginning, while this talk is focused on prevention and intervention strategies for co-occurring issues specifically, there's been a lot of great work and done focused specifically on suicide prevention initiatives. So for example, Carla mentioned the Federal Framework for Suicide Prevention, which is a really great document, and I've highlighted this document in my resource tab at the back of my deck, so if anyone's interested in looking at that. There's also the Canadian Association for Suicide Prevention, which is a national organization focused on suicide prevention, and there's the National Collaboration for Suicide Prevention as well. So there's really great initiatives and many initiatives focusing on suicide prevention. And as well, there's some initiatives on substance use prevention. So for example, at CCSA, we have the Prevention Hub Canada, and also the Canadian Standards for Community-Based Youth Substance Abuse Prevention, which was a 5-year strategy launched in 2007. So there's some great work going on in both of these areas separately. When we look at co-occurrence of substance use and suicide, there lacks any national prevention strategies, and there's a substantial gap in any prevention initiatives addressing the co-occurrence of two. So on this particular slide, I've just highlighted some examples of organizations who do offer some prevention initiatives in relation to substance use and suicide behaviors. So certainly this is not exhaustive, it's just some examples of some resources that you might be interested in looking at. So the Center for Suicide Prevention has a Substance Use Disorder and Suicide Prevention Resource Toolkit. The Center for Addiction and Mental Health, or CAMH, has a handbook on suicide prevention and assessment where they focus on identifying substance use as a risk factor. And the Canadian Association for Suicide Prevention, or CAS, which I've mentioned, promotes the use of tools from the U.S. that identify problematic substance use as a warning sign. So ISPATH WARM is an acronym created by the American Association of Suicidality to help counselors and the general public remember the warning signs of suicide. So just a few resources to keep in mind if you're looking for some resources that focus specifically on co-occurring issues. So because of the numerous factors that can contribute to suicide risk, effective ways to prevent suicide and suicide behaviors will likely require a comprehensive and multifaceted approach. So I'm going to discuss a few different approaches today. The first is increasing awareness and training for healthcare practitioners. So to address suicide prevention among youth with co-occurring issues, healthcare providers should have training to identify and address the signs of both suicide risk and substance use. So this is really important when we consider that 45% of individuals who completed suicide had contact with their primary care providers within 1 month of their death. Helping healthcare providers to understand the link between substance use and suicide and then to enhance their capacity to address these issues is really important. The American Academy of Pediatrics has recommended that pediatricians and family practitioners routinely assess adolescents for risk factors on suicide, including substance use. So although training primary care providers on the links between substance use and suicide among youth has not been evaluated, there was a randomized control trial that involved training primary care providers to deliver evidence-based treatment for adolescent depression, and this was tied to fewer suicide attempts, suggesting that primary care providers could be an important target group for future prevention initiatives. So I also wanted to discuss several protocols that have been developed for health service providers that focus on co-occurring issues. So for example, Treatment Improvement Protocol number 50 from SAMHSA, or the Substance Abuse and Mental Health Service Administration, provides guidance to help frontline substance use counselors, supervisors, and program administrators deal with suicide risk. So this program hasn't been evaluated among addiction service providers who work with youth, but there was a study among treatment providers for veterans with substance use disorders, and the program was associated with significantly increased knowledge and self-efficacy immediately following the training, and higher self-efficacy and use of suicide risk management behaviors 2 months after the training, so showing some findings that remained after the training. As well, I wanted to mention the Question, Persuade, Refer, brief standardized community gatekeeper training. So this program is meant to teach a wide range of staff how to identify and refer individuals into care. So it's a 1 to 2 hour instructor-led lesson, and it provides opportunities really for practicing scripts and practicing the gatekeeping skills in small groups. And this method was piloted among 50 problematic substance use treatment professionals, and was associated with significant gains and higher perceived self-efficacy immediately following the training. But there was no follow-up for this evaluation, so it's uncertain whether the gains promoted greater use of this approach on the job. And finally, I wanted to mention Preventing Addiction-Related Suicide, a program that has been developed and pilot tested to address co-occurrence of substance use and suicide prevention. So this is a group-based suicide prevention program. It includes about 2 to 3 hours of training for addiction counselors. The counselors then lead a 2 to 3 hour group session with their clients, who are typically in outpatient treatment programs, and it teaches information on the risk factors of suicide, the warning signs of suicide, and the links between suicide and addiction, as well as steps to address suicide risk in oneself and others. So there was also a study using this program among 78 clients in treatment in an outpatient addiction group. And the program was associated with significant more help-seeking behaviors when suicide issues arose for the clients. Although this approach, we should mention, hasn't been tested among adolescents, it could be applicable to adolescents in day hospital or residential addiction programs. Certainly, you know, despite that there's potential in these programs, they really have not been evaluated among youth. So their efficacy for enhancing suicide risk management among youth is unknown. Certainly evaluations are needed in this regard. So another approach that I wanted to discuss briefly is focusing on policy. So a possible approach to help prevent suicides in youth is to examine policies surrounding the regulation of substances. So there's a few examples in other countries whereby various prevention efforts and policies aimed at reducing substance use appeared to impact suicide rates. So in Estonia, they implemented various approaches to reduce alcohol use and related harms. They used media campaigns, restrictive policies aimed at reducing alcohol production and increasing the prices of alcohol, and improved treatment for alcohol use disorders. These policies were associated with a 40% decrease in suicide, in which the blood alcohol was detected among all ages. However, following the end of the campaign, I should mention the number of suicides where alcohol was detected began to rise again. So in Russia, there was an anti-alcohol campaign involving strategies such as increasing alcohol prices. They also restricted time of sales and gave stricter punishment for public intoxication. and this was related to a 33% decline in violent deaths, including suicide during its duration. Legislation was also passed in Slovenia in 2003 to limit the availability of alcohol products and establish a minimum drinking age of 18, and this revealed an immediate and persistent reduction in male suicide mortality following implementation. So these are just some examples, keeping in mind what other countries have done in terms of policy changes, really focusing on substance use, but the potential impact it could have on suicide. It's really not clear if similar policy changes in Canada would also be effective. So changing gears a little bit, I just wanted to focus on community-based interventions. So community initiatives can be really important when we consider postvention. So postvention, for those of you unfamiliar with this term, is the provision of supports or interventions for those exposed to a suicide. And it's really an important component to suicide prevention, particularly among youth, as postvention could help decrease the risk of suicide contagion. So suicide contagion is that the exposure to someone who died by suicide, either by knowing that person or through media potentially, is linked to subsequent suicide thoughts or attempts. So there are some reports documenting evidence for suicide contagion among youth. A Canadian study using the Canadian National Longitudinal Survey of Children and Youth aged 12 to 17 years observed an increased risk of suicide behaviors in youth exposed to suicide. Youth tend to be more affected by the suicide contagion than adults, with some reports indicating that clusters of suicide account for anywhere from 1 to 5% of adolescent suicide deaths. Now, an example of community initiatives, I wanted to provide an example of one that we have a report on by Hacker et al. You can see if you're curious to know more about this particular initiative. It was in the U.S., and what happened was there was a cluster of 11 suicides linked to problematic substance use and 10 deaths by opioid overdoses among youth aged 16 to 24 in the community in the United States. So they rolled out a comprehensive approach to respond to the crisis, and like I mentioned, there's a report on this, and it's the only report on a community-based prevention strategy for a series of suicides linked to substance use that we could find. This approach used a community-driven approach, and it included a number of different factors. So they developed a surveillance system. They needed really to have a good surveillance system to monitor their data around suicide. They designated hospital beds for those in crisis. They provided post-traumatic stress management for those in contact with youth. They held educational forums to teach the signs and symptoms of problematic substance use and made efforts to link those with problematic substance use to their needed resources. And they also provided media training for non-sensational reporting. So following this initiative for 2 years after the implementation, only one suicide among 10 to 14-year-olds occurred, as well self-injuries were reduced to a lower rate than the rest of the state, and non-fatal opioid-related hospital discharges began to trend downwards. So this was just an important example of community-based initiatives, and such initiatives, determining how these could potentially be applied to other communities is an important area for further investigation. So community-based participatory research is a program that's been examined among Indigenous youth, and it involves communities being part of every aspect of the research process. These programs have appeared to be promising because they really focus on cultural enhancement for life promotion. This approach can involve reducing the negative impact of risk factors, so really focusing on reducing the negative impacts on factors such as a breakdown of cultural values and a loss of cultural identity, while also really focusing on promoting protective factors such as the meaning of life, self-esteem, and belonging. So there was a report using the community-based participatory research to prevent suicide and alcohol use, and it was adopted for Indigenous youth in Alaska. The approach provided 3 communities with toolkits of options for enhancing protective factors. Some of the protective factors were self-efficacy, limits on alcohol, family members modeling sobriety, positive community and family familial factors, just to name a few. And the program was associated with the promotion of several shared protective factors against alcohol use and suicide. Again, I cited this source for anyone who's interested in knowing more about this particular report. It's certainly important to note that what works in some communities will not necessarily work in others, and so approaches such as this community-based participatory research that acknowledges community expertise and involves culturally driven models of prevention seem to be promising when addressing co-occurring substance use and suicide among youth, particularly among Indigenous youth. Supporting communities in their efforts to evaluate ongoing prevention strategies will be helpful in informing other communities that are looking to adopt new approaches. Certainly we know that not all Indigenous communities have high rates of suicide, and understanding the reasons for these disparities are also helpful for informing prevention initiatives. So in fact, in this particular article, they did examine whether protective factors from alcohol, for example, were more important concern in some communities versus others, and did find that differences between the communities existed. So one community that experienced several alcohol-related suicides then wanted to place limits on alcohol, which were more focused on and emphasized as protective factors in that particular community. So the next suggestion is really incorporating suicide prevention through treatment provision. So I'll provide an example highlighting the need for this suggestion. A series of suicides occurred in New Brunswick, and the provincial government commissioned several researchers to audit the cases that had occurred. What they found was that 85% of the deceased had contacted mental health or addiction services at least once in the year prior to death. And although 59% of those who died by suicide had problematic substance use or dependency issues, addiction services were only accessed by 3% in the month prior to suicide and 4% in the year prior. So the researchers identified 2 gaps that were especially relevant for most cases. The first was the need for better promotion of integrated treatment for mental health, substance use, and suicide behaviors. The second was the need to enhance public awareness of the occurrence of these issues to encourage people to access healthcare services. And there was also an unmet need for healthcare personnel trained to identify, treat, and refer those at risk of suicides. One of their recommendations from this report was providing further training to primary care providers in mental health, addictions, and suicide, and how to refer patients to care. So we know that substance use and suicide behaviors often co-occur in youth, but the current standard of care is to treat these issues separately. When we know, though, when youth with co-occurring issues are referred to separate treatment systems, so separate addictions and mental health systems, they're less likely to receive the treatment they need. And there's also a significant burden that comes along with accessing different treatment systems. The issue is really the lack of collaboration between addiction and mental health systems. In Canada, we know there's a need for enhanced collaboration for addiction and mental health care. This is highlighted as a priority for improving the outcomes of people with co-occurring issues. So CCSA, together with the Mental Health Commission of Canada and the Canadian Executive Council on Addictions, released a document on best advice for collaboration of addiction and mental health care. I've just shown a picture of this on the slide here. And this report is available on our website, and also I've included as a link in our resource page at the back of this deck. So there's also some suggestions that speak to the efficacy of concurrently treating problematic substance use and suicidality using various forms of therapy. But I will say that evidence is certainly limited. For example, when we consider dialectical behavioral therapy, this therapy helps increase emotional and cognitive regulation to change patterns of behavior. And it has been assessed among those with with borderline personality disorder who had at least 2 suicide attempts in the past year. And what they found in this particular study was higher rates of abstinence and fewer suicide attempts were observed at 24 months following those who had received dialectical behavioral therapy. And this was compared to those receiving community behavioral therapy. So dialectical behavioral therapy was originally developed for those with borderline personality disorder and suicidality, but it's been suggested that DBT might be really suitable for frontline treatment for those with a substance use disorder and suicidality and those who do not necessarily have a borderline personality disorder. So this is a possible and potential therapy that could be effective for dealing with co-occurring issues, but certainly among adolescents, more research is needed, as the studies to date have really not focused on the simultaneously targeting substance use and suicidality among adolescents. There have been a few studies focusing on integrated cognitive behavioral therapy. So integrated cognitive behavioral therapy is really geared towards those with problematic substance use and co-occurring issues. This technique has been used and can be used to limit maladaptive thoughts and behaviors that underlie both suicidality and substance use. And there was a study, a randomized control trial of adolescents who were 13 to 17 years old and had co-occurring suicidality and alcohol or cannabis use dependence. And so what they found in the study was that individuals who underwent the integrated cognitive behavioral therapy expressed fewer heavy drinking days, fewer cannabis use days, and cannabis-related problems over the protocol, and that was compared to treatment as usual. And as well, adolescents who received the integrated cognitive behavioral therapy had fewer suicide attempts, fewer emergency room visits, psychiatric hospitalizations, and arrests compared to those in the treatment as usual group. So this protocol required substantial resources, but it was also associated with the decrease in service use. And certainly integrated cognitive behavioral therapy is an area that seems fairly promising when dealing with co-occurring issues. So we know that co-occurring issues are complex and difficult to treat, and therefore effective strategies will also need to be complex and multi-pronged. So with that, I think that I'm just going to provide a summary of what I've talked about today, just highlighting some of the important findings. So we know certainly that substance use and suicide frequently co-occur among youth, and they do represent a significant burden to society. Substance use is a significant risk factor for suicide ideation, attempts, and completed suicide. Current research on effective interventions and prevention initiatives is really preliminary, and there are many gaps that remain in our understanding of these links between substance use and suicide. But suicide prevention resources have been developed for healthcare practitioners and others who come into contact with the individual who have substance use issues. Certainly, though, further evaluations are needed to evaluate the impact of these prevention resources. And although the available evidence is limited, there are some promising emerging treatment strategies for youth with co-occurring substance use and suicidality. So, we have just a shameless plug here. We have an Issues of Substance conference coming up in November in Calgary in 2017. Anyone interested? And with that, I'll just move to questions.
That's great. Thanks very much, Robin, for a great presentation. We do have a number of questions that have come in already during the course of the presentation, but I would encourage anyone else, if you do have any questions for Robin, we've got about 10 or 15 minutes for discussion, questions, and thoughts. So please type those into the chat feature right now. And just a reminder, when you're sending us your questions, if you can select all panelists from the drop-down menu, then we'll be able to ask some questions on your behalf. So one quick question for you, Robin. You were just talking about the integrated cognitive behavioral therapy. I'm just wondering if you can comment a little bit on how that's different maybe from traditional cognitive behavior therapy.
Sure. So I mean, it is a form of cognitive behavioral therapy, certainly. And I think that the real difference is that it's just geared towards individuals with co-occurring issues. So the focus is really on not just one main priority issue, but on the co-occurrence of the two, if that helps. And I can certainly send papers to anyone interested in it. I'm not, like, I haven't sat in on integrated cognitive behavioral therapy sessions. I'm not a clinician, but certainly I can share those resources with anyone interested to find out more.
That's great. Thanks, Robin. And I'm sure people can look up some additional information on that if they're interested as well. We have another question. A couple of people have actually written in on kind of this same topic or theme, but just wondering whether or not there's any evidence around the effectiveness of suicide prevention programs that might be delivered through educational institutions or any school-based programs.
Yeah, that's a really great question. That has not come up in our, not to say it does not exist, it hasn't come up in our scanning of the literature and our findings. I would suspect that there should be some. I know that it's been suggested that while I've talked a lot about primary care and focusing on screening in primary care for substance use and suicidality, it's also been suggested that this could be happening in the education systems. So placing not just the burden on primary care, but also among educators and among, you know, this could be taking place in emergency room departments. And so I'm not sure if there are specific programs that have been evaluated. They're probably taking place and we didn't find any actual evaluations on them, but certainly I think it's a great area to look into further and certainly could be done within the school system.
That's great. Thanks, Robin. Earlier in your presentation, you talked about, I think in the section where you were talking about at-risk populations, and you were certainly mentioning Indigenous youth as well as LGBT youth. But I'm wondering whether there's been any research on ethnic minority groups, and thinking specifically about maybe refugees or new immigrants that are settling in Canada, whether there's been any work on that particular population.
That's a great question. I certainly know that that's been an area of interest, especially with what's happening right now, and it's been an area that certainly has been discussed a lot, I think, in terms of suicide especially, but I haven't seen anything that focuses on the co-occurring issues. Again, the literature is fairly light when we come to looking at co-occurring issues, but certainly it could be out there and we hadn't found it, but certainly focused on the LGBT and Indigenous groups. But I would think that there's likely something on refugees, and perhaps it just didn't come up in our scanning of the literature.
That's great. Thanks, Robin. And a few people have also been writing in about other courses and training programs that are available. I know that you highlighted a couple in the presentation, but I know certainly that mental health first aid, which is offered by the Mental Health Commission, does have a component that looks at alcohol use, and certainly also how to kind of direct people that may be at risk for suicide. And someone else has just written in as well about the ASSIST program, which is offered by Living Works. So just as an FYI for those on the line, there are certainly some other programs available as well. And Robin, we did have a question as well. You had a lot of really great detailed data and statistics that you were sharing with the group today. Do you have any suggestions if people are looking for more detailed information on any of the statistics within their local communities, on where you would direct them to find that information?
That's great. That's a great question. So a lot of the statistics that we get in terms of substance use data are from CTADS, the Canadian Tobacco and Alcohol Survey, and there's also the CSTAD, so that's among students, so looking at illicit substances, and those can all be found on the Statistics Canada websites. And you can break down those, so you can get them nationally, but you can break them down by province. But I have looked into breaking them down further, and you cannot break them down further into the community level. So really, you'll be able to get your provincial statistics or territorial statistics through CTADS or CSTADS. And then in terms of some of the substance use disorders or mental illnesses, we often use the Canadian Community Health Survey. And again, you can look at that by provinces as well and territories, but you cannot further break them down. So I think that that's something that is one of our challenges, is that it's tough to find the statistics that we're looking for example, within Ottawa instead of Ontario, and that is a challenge certainly for us as well at CCSA.
Great, and I might recommend to people as well, I know at least within the Ottawa area, the Ottawa Public Health Department does have some statistics and some data that are available through them as well, so that might be the case in other municipal jurisdictions also. Robin, we've had a couple of questions that also relate to sort of the involvement of families and caregivers. Just wondering whether you've come across any research that looks at sort of the importance of the role of family or how caregivers can support youth that might be at risk.
Yeah, absolutely. I think that that's really important. Certainly in the Integrative Cognitive Behavioral Therapy study, they did include families in some of these sessions. So instead of just doing individual sessions, they included involving family sessions and as well parent sessions to help facilitate skills such as communication and monitoring and emotion regulation. So I think it certainly is part of some of the therapies that I've spoken about today, and that's a great point.
Thanks, Robin. There was another point where you were talking about one of the pilots or trials that had gone on as one of the community initiatives where post-traumatic stress management was being offered, and I think that you mentioned that program was being directed to people working with at-risk youth, but I'm just wondering if you have any more details on that particular component and whether it was offered to youth or whether it was offered to those that were working with the youth.
Yeah, my understanding of that was that it was offered to those working with the youth as well as the youth. I'd have to pull up the original article again to find that, but that was my understanding, was that it was to anyone who was in contact with the youth, so those healthcare providers, as well as the youth who were also in crisis.
Great, thanks, Robin. We have another question. You may have answered this through the course of your presentation, but I'll just come back to it in case you have any other thoughts. But right at the beginning, when you were providing a bit of the context around the number of suicides, you mentioned that the number of deaths by suicide in Canada was higher for males, but the number of attempts was higher for females. So just wondering if you could expand a little bit on sort of why we might be seeing that trend.
Sure. It differs based on also the means that are chosen for suicide. So I think that there is, as I mentioned as well, more females who use substance-related means. So more females who use opioids, and it's more that there's more unsuccessful attempts, whereas males are more likely to use certain means that are more successful. So there's, in one particular study, males are more likely to use a shooting, but males are also more likely to use hanging, and females are more likely poisoning. So I think it's that the means are not always females who use poisonings are not always successful. So that turns out that the statistics then would be more attempts among females, but more suicide completions among males. I hope that makes sense.
Yeah, no, that does. Thanks, Robin, for clarifying that. We have quite a few people that are writing in and providing us with some information on different programs that might be available in their community, including Alain, thank you for sending the recommendation on a school-based program that you're running in Quebec called Partners for Life. So we'll assemble some of that information as well as some of the other school-based programs that we're aware of as well, and send that out to people as a follow-up. We've obviously generated a lot of discussion and interest on the subject of data, so people are commenting about some of the data and statistics being out of date and old, which we know is a problem when we're trying to do research on suicide, that a lot of the statistics that come through from CHI and Stats Canada tend to be quite dated by the time, you know, they're analyzed. But some great suggestions as well for people that if you're looking for regional data, again, to maybe reach out to your police or your RCMP detachments. You might be able to get some data through your coroner's office and your regional health authorities. So thank you for people that have provided those suggestions as well. So we're coming up just to the close of our webinar. So Robin has also provided you with a number of links and resources to some of the studies that she talked about. So you'll have access to that when we send out the slides to you. So you will have access to them from the website in about 2 weeks' time. You can also contact Samantha directly if you'd like a copy of those earlier. So we'll make sure that you get that information. I also wanted to let you know that our next webinar in our series on suicide prevention is going to be held on Thursday, May the 18th. So again, that will be starting at 1 o'clock Eastern, and we'll make sure that you all get the right time in your calendars for that. So we hope that you'll join us for that, and we'll send you out some invitations closer to the date. And also wanted to let you know that when you close the window for the webinar today, there's a very, very short survey. We'd really encourage you just to take a few moments to provide us with some suggestions, maybe for topics for future webinars or other areas related to suicide prevention where you might be interested in having some sessions, as well as providing us with some feedback on the webinar that we hosted today. And so again, thank you everyone for joining us for this session. A special thank you to you, Robin, for joining us and sharing all of your expertise and all of these tremendous resources with us. And we do have contact information for our team here at the Commission, and I want to thank the folks here that have been working behind the scenes, Amy, Samantha, and Sophia, for all their help in this session. You're certainly welcome to reach out to Samantha or myself or to Robin if you'd like some further information on this topic. So thank you again on behalf of the Mental Health Commission for joining us, and we look forward to hosting you at a future session. Hope you all have a great day.